Yes, about 5 years ago, we reported on the first results from the IBIS-2 prevention trial, which used the aromatase inhibitor anastrozole to try to prevent cancer before it occurred in postmenopausal women. And the results were good, but the follow-up was only 5 years. And there was no long-term follow-up for aromatase inhibitors for prevention. Recently, we showed that tamoxifen, if you give it for 5 years, the benefits last at least 20 years, but they're only about 30% per year. So we looked at this and we saw about a 55% effect previously, and we've now updated the data out to about 12 years. And to our great pleasure and excitement, the results have maintained quite strong right out to 12 years. So there's about a 60% reduction in the first 5 years, and then another 36% year on year after that. So even in the longer term follow-up, it's still working better than tamoxifen, so we're excited about that. We have a complicated algorithm, but basically simply the most common way to become high risk is to have a mother or sister who had a breast cancer below the age of 50, or 2 breast cancers in the family, or dense breasts, which wasn't used so much, or atypical hyperplasia and a benign lesion. Yeah, one of the things we're very pleased about, one of the concerns about aromatase inhibitors is that they lead to higher fracture rates. Now, in this trial, we made sure everybody had a DEXA scan to look at their bones before they started, and if they were osteoporotic or osteopenic, insisted that they take a bisphosphonate to control their bones. So there was a small increase of risk in fractures in the 5 years of active treatment, about 10%, and it's now virtually completely gone. There's fewer fractures in the follow-up period. So overall, there's virtually no increase in fractures, so that was very good. The other thing about aromatase inhibitors is they do cause aches and pains and arthralgias. And we haven't looked at that in the long-term follow-up because that's basically only done in a clinic visit. And it generally, if you're going to get that, you know about that in a year or two. So we haven't looked at that any further. But there are no other long-term side effects that are negative. No increase in other cancers, no increase in deaths from other causes, no increase in heart disease. And the only other thing we found, which was quite surprising, was that we found a substantial increase in non-melanoma skin cancer, about a 50% reduction there as well. It's not a very serious cancer, but it is of interest that that actually was clearly happening. I think anastrozole got in a little bit late in the game for prevention, so it's not been formally licensed for prevention because that has to be done by the companies, and because the drug's off patent, there's no desire to do that. But in the UK, it's been recommended by NICE, and in the United States by the United States Preventive Services Task Force. So that just happened in 2017. So there's, I think, still some concern about side effects. The other interesting thing is we found that if we looked at the proportion of women who completed 5 years of treatment, it was 77% on placebo, but 74.6, or just slightly lower, in the anastrozole arm, indicating that most of the reasons for stopping treatment were not side effects, but for other reasons. And so that was one of the main concerns about side effects, but in fact, a similar number of women managed to carry on with the treatment on the active arm. The aromatase inhibitors, including anastrozole, are only suitable for post-menopausal women. So for premenopausal women, it's still tamoxifen as a drug of choice. For postmenopausal women, the benefits in terms of breast cancer reduction are much bigger for anastrozole. There aren't the serious side effects like endometrial cancer or deep vein thrombosis, which are seen with tamoxifen occasionally. So there appear to be no really serious side effects. And the only concern is about arthralgias. So women that have a lot of trouble with that might not want to, but we would think it's the drug of first choice for every woman, virtually every woman. And if they can't tolerate it, then tamoxifen would be the second choice. Well, the next steps are, it's still too early, even with 12 years of follow-up, to look at mortality. We've had 3 deaths in the placebo arm and 2 deaths in the anastrozole arm from breast cancer, and overall the deaths are split as about 70 in each arm. So we need another 10 years follow-up to see whether or not these reductions in incidence will translate into reductions in mortality. I'm optimistic they will, but you never know until you've actually done the data. So those will be the next steps. There also are a range of biomarker studies to be done to try to understand a bit better who's responding best to anastrozole, and ideally identifying who's likely to have the side effects. I think that's good. I mean, the bit on compliance is really important. I said a bit about that, or adherence is the proper word, but in fact, only 2.5% more women didn't complete their 5 years of treatment compared to the placebo arm, indicating that most of these side effects are really relatively short-term and tolerated. They tend to sort of be tolerated within 3 to 6 months. You don't see much after that that's new.